It's a great presentation, Alan. I mean, I think our group has been very excited about this work. If you read on, reconstruction and head and neck, you always see the same kind of sentence that starts the majority of papers like this. It's that the pectoralis flap has been the workhorse of reconstruction or mainstay of reconstruction. And I think as we advance, I think that kind of thought process or idea is changing, and this paper really helps people to understand, why it should change and how we can continue to move to the next stage of kind of pedicle reconstruction, just like we moved on to the next stage of free tissue reconstruction.
Yeah, great. This is a very comprehensive study. I saw the team collaboration even in the flap harvest step and to the anatomy and shoulder function. It's a very instructive to our practice. And also, I like the way that Dr. Feng delivers this study. He also provides a lot of literature supporting this study. That's cool. I believe this is how a good idea come out, isn't it? Should we start the QA section now? I guess our speakers are expecting for the question from the panel. Can we start it?
I guess the question I can direct at Dr. Spector or even Dr. Feng. Can you comment, how do you convince, people that this is a good alternative, because the pectoralis major flap is, almost anywhere you go is, a mainstay if you don't have free tissue or if you do have free tissue, particularly given some of the positioning challenges, because it's overcoming decades of, technique and institutional bias.
Yeah, I can touch on that a little bit, especially since I'm thinking about some of these things as I kind of transition away from my fellowship to my practice next year. But as you mentioned, it's kind of tough changing decades worth of institutional practice when you try and introduce these new things. And I think one of the big things really is the positioning and kind of the harvest aspect of it. And this is, again, something that I've kind of thought about. So we mentioned the spider arm and kind of how that's used for the approach for the exposure, but I touched on it a little bit. I think it's important to note that specifically for the latissimus dorsi flap, when you're harvesting, you don't necessarily need all these need that extensive of a setup. You can actually do it 90 degrees on an arm board, kind of very similar to other different free flaps that are harvested that people are actually a lot more familiar with, right? So people work around people harvesting for radial forearms all the time in a very similar position, and you actually get good access with that. So having a setup that people are familiar with and kind of introducing it in that manner. The other argument is a spider arm. There's significant costs associated with that, right? So a new spider arm, if your institution doesn't have it for whatever reason, or their orthopedic department doesn't utilize that technology, can cost $50,000 to $20,000. But if you can do the harvest, from a more lower cost perspective too, in a more familiar position, I think that kind of helps people to adopt the idea a little bit.
Could you also comment on the arc of rotation variance between the pec and the lat?
Yeah, so I think it's pretty well described for the pec. It can reach, it's been a workhorse for many years for a few reasons, right? So it can reach pretty far, reaching lateral defects as well, covering a temporal bone for after lateral temporal bone defects even, and stretching up relatively far that way. So for the latissimus flap, as long as you take down that circumflex artery, it actually provides a pretty decent arc of rotation. A little bit of it is dependent on patient body habitus, and there's been a couple of cases that we've done this year anyway that have been a little bit more limiting than others, but it's not necessarily that we're suggesting to use this for every single kind of defect like oral cavity defects, although you could certainly try and stretch it up that far. But these are typically used for broader coverage, for neck coverage, neck resurfacing, carotid coverage, oftentimes for total laryngectomies when you're doing an onlay. and especially in revision cases if you're doing a salvage neck dissection. So you could certainly try and push the limits a little bit and stretch it up to those lateral defects, but that would kind of be pushing the envelope a little bit. And then also you would have to harvest the latissimus muscle itself a little bit lower, right? And the issue also becomes whether or not you're going to take skin with that, where the perforators are located, which are generally centered around the scapular tip area itself. There's kind of those 3 regions or zones that we think about in terms of skin perforators. And then the muscle itself too, if you go lower and lower, it's not really based on that latissimus branch itself. It's the intercostals that also supply the more inferior part of the muscle. So the body habitus is a little bit limiting, but you can stretch it up to those lateral superior kind of defects just based on the patient, but those typically aren't the situations where you're thinking about a pec to be, or a latissimus versus pec to begin with. So. And I had a question for Dr. Spector as well. Am I allowed to ask questions too, even though I'm a speaker? Just kind of in your practice, when you think about using latissimus flaps, I guess I talked about it a little bit, but when you specifically think about, using them, and especially let's say like for a patient undergoing a salvage total laryngectomy where you're going to do an on-lay flap, the difference between that and doing an ALT, do you really think there is a difference in terms of operative time, or how do you kind of triage what kind of tissue you're going to put up there?
I think thanks for that, Alan. I think the first question is the patient can maybe tell you what their goals are, right? And so a person that's doing a lot more with their arms, or maybe they're a big walker, maybe they want to stay away from an ALT. So just asking a patient, I mean, would you rather have this from your shoulder or your leg? I do think they're equal. I can't see a reason why you could say that an ALT versus a latissimus would give you a different outcome in terms of the wound that you're trying to treat. I do think it'd be a different donor site and certainly has a different morbidity. I mean, you don't have to do a free flap if you do a pedicle latissimus, right? So that would save you an anastomosis and that trouble. But otherwise, I think the wound that you're treating would be the same, just what the patient wishes might be in terms of the donor site morbidity, and then the difficulty of the operation as well. So.
Yeah, like that comment too. I think the other thing to think about is I often will save the pedicle lat in those situations as a bailout, because in a vessel poor neck or in a hostile neck, I will typically go with free tissue up front. But, if there is a problem, if there's an additional leak or whatnot, sometimes having that pedicle option as a bailout is kind of why I like to usually not use it as a primary. And kind of just use it if I need to in certain situations.
Great. And one follow-up question I actually had for that is kind of for really for any of the panelists or who've had experience with this, or really lots for the pedicle lat in particular, whether or not you've used it as a tubed option and not necessarily just as an onlay for reconstruction of the pharynx as well for those cases, and kind of any of the difficulties you encounter with that, or whether or not you've had to do that in your practice.
No, I have not tubed a pedicle lat. I've tubed a free lat, but I've never pedicle lat. Matt, have you?
I have not. No, I be asking a lot, right? Because it would change how you would deal with the overlying skin, right? It changes how you deal with the native neck skin, and it might even change the direction that you tubed it. And I don't know how the pedicle would reach, right? And so you either have to flip it 180 degrees, the pedicle, if you're not putting skin in, or you have to do a completely kind of rotational. And by tubing it, you're going to put some type of twist on it. I'd have to think about exactly how it was going to be done, but maybe it's still 180 with a suture line on the back but I think, and then it's always a funny direction, right? Because it's not always completely at the same arc of rotation. The pedicle can get turned in a different way as it comes through the neck. And so it would create more tension somewhere. And I can't quite picture how it would create that tension. So I would be very careful doing that.
Maybe if you did it, I mean, I've never harvested a pedicle Tdap, if you were able to separate it completely from, the muscle, because that's one of the concerns, just like the pec, is some of the shearing of the skin. The perforator are a little bit more robust, but that would be that's the only way I could possibly think of it. But I think, it's usually, I typically use it for an overlay, or for neck resurfacing. I've done it for floor mouth resurfacing in a really bad fistula, but that's about the limitations, just like with the pec. I mean, I guess people do talk about tubing pectoralis flaps. So.
Sorry, I received a note from Dr. Nolan Seim. He cannot make it today, but he dropped me 2 questions. One is, do you routinely refer patients for PT after scapular system or pectoral harvest? And what type of improvement outcome could one expected with earlier intervention? About surgical timing, I guess. This is the first question.
So I don't routinely refer patients for physical therapy afterward. If they're asking for it, I do. But a lot of patients get recovery. I mean, it may be something we should be doing more of. It's something certainly to think about. But I don't routinely do that. I think they're different, right? If you're doing bone work with scapula, I think sometimes you have to wait till everything heals in to make sure that they're going to be, everything's healed first. But I think a latissimus could have early PT, or even a neck dissection. I mean, we don't refer neck dissection for early PT. That's something that we maybe should be doing either way to help with that. But no, we're not referring people routinely.
Okay. Also, he asked, what is the superior reach of the pedicle lateral flap in your experience?
I think Steve has the highest one there. I think the flora mouth, I think it would reach the flora mouth. I think it's a lot like a pec flap though. I mean, you can get it to go anywhere, right? The question is it the right thing to do? And is it actually going to survive that area? I mean, the pectoralis flap is easier to understand its reach, right? Because the muscle ends at at a certain level. And if you take skin beyond there, you run a risk of having that, part, die. Whereas a latissimus flap, you can kind of take it as far down as you want, right? I mean, because the pedicle runs all the way down through the latissimus, but whether it's going to survive down there is harder to understand than the pec flap. So, I mean, flora mouth defects and tongue defects are certainly reachable with latissimus. It's, once you get in there, is it the right kind of functional outcome that you want to put the latissimus intraorally to allow the tongue to be tethered down by a flap like that? And so for us, I think, again, it's a neck resurfacing, carotid coverage, onlays for laryngectomies. Whereas we get higher up in the oral cavity, the goals of reconstruction are very, very different at that point, right? It's the maintenance of elevation and protrusion of the tongue. You know what I mean? So the ability for the tongue to, bring secretions back to the back of the mouth, and then deglutition where the tongue can push up. So those are very different from a pedicled flap that would pull things down, as opposed to an anterior neck or lateral neck reconstruction, down lower.
I think one of the other challenges with, how high you're trying to pull it superiorly is that arc of rotation on the pedicle. One of the things that I was trained to do was to tack the pedicle, some of the fascia around the pedicle, down onto some of the pec minor muscles, so it doesn't get pulled, because as the muscle swells, it can sometimes get pulled through the tunnel and actually cause venous congestion on the flap. So there's one of the limitations is I do usually tack it just so it has some sort of downward anchoring, so you can't pull it too far in and actually twist or kink, particularly the vein. So that does limit also how far you can pull it. I think the other thing that no one's really commented about, one of the downsides of the pec, is the cosmetic aspect of it. To have that anterior chest wall, particularly in women, can be, functionally or not functionally devastating, but also cosmetically deforming, whereas the latissimus does not have that. And so again, another pro, I guess, for the latissimus flap.
Another question I kind of posed to the panelists who have experience with this is how big of a tunnel do you find that you have to make for the pedicle latissimus versus the pec? The pec flap is obviously much more robust, as you have to kind of tunnel it through, needs a little bit more space, but how big do you think about making that tunnel through the pec major when you're swinging up the latissimus?
I think as small as you can possibly make it to get the flap through. And so, for a very thin patient with a thin latissimus muscle, I mean, the pedicle doesn't need room to go through, right? A pedicle, you would deal with a 60 French dilator would be plenty of room for you to fit a pedicle through, right? That's probably what we use for a connection like that with the Hagar dilators. For the flap, I mean, you want to make just enough to get it through, but not enough to create a secondary wound. And so whether that's 3 fingers or 4 fingers or whatever the distance of your kind of latissimus muscle might be. So if it's a very narrow resurfacing area, maybe 4 centimeters, maybe you need, just to be able to get, a single, retractor through there to get it. But if you need if you're doing a wide resurfacing, one like a few weeks ago where we needed 8 centimeters or 9 centimeters with skin that we're bringing up, I mean, that's not going to come through, and you could shear it as you bring it through, which is the danger. And so, a number of options exist, right? You can use Babcocks to pull it through, which is, what we did a couple of weeks ago. You could put it in a kidney bag. That's what Doug Chapea used to do from Toronto. So you get a kidney bag that they would use for these laparoscopic assisted nephrectomies, put the flap in a kidney bag and then put clamps on that and then pull the bag through. So that's another way to possibly do it. But I think it's kind of like the same, how big do you make a floor mouth defect to get into your neck with a hemigloss? It's basically just enough to get the flap in there so you don't have to, have a huge fistula risk. So.
And thank you. And at the risk of making this too Michigan centric, Dr. Kain, for your experience at UC Davis, just in general, in terms of approaching these kind of neck resurfacing cases, carotid coverage cases, is it the latissimus, or components of the subscapular system that are used by you guys, or do you default to the ALT, or and kind of how do you approach your harvest to the subscapular system, and just kind of what your guys' experience is like? I'd just be interested to know.
Definitely. Well, it's great to see familiar faces, and hello to everyone. But I would say we're very ALT heavy. We benefit from relatively thin people, and so we get to use the ALT a lot, even when we don't need a big volume of tissue, just because of the general habitus in this area. And that's very different from my residency, and so we hardly ever use an ALT. But I think that we are apt to use the subscapular system. We've done some TDAP perforator-based flaps for skin only, and small cup of associated latissimus. But one flap in particular, I know we ran into distal necrosis in the muscle because we got beyond kind of that intercostal supply distally that you mentioned earlier. And I was wondering if y'all have run into that, and kind of how you gauge the distal extent of what you're going to take in terms of the muscle.
Yeah, we just don't push the limit of what we need to take there, right? So as I think Alan mentioned before, the zone 1 around the scapular tip is certainly all fair game, but you can get, at least 8 to 10 centimeters of muscle from the pedicle insertion. So if the pedicle's, 6 to 8 centimeters, you can get another 6 to 8 centimeters of muscle pretty easily from there. And, the funny thing about the muscle is that when you do free latissimus dorsi muscle transfers, I mean, you can get 20 by 20 centimeters. So, the whole muscle can run off of that single pedicle. And that's resurfacing the whole scalp, right? Those are, can be 20 by 20. And so it's not the muscle I actually worry about. It's really the placement of that skin paddle, just like on the pec flap, right? If you want a pec flap to get intraorally, that thing's got to be distal. And so a latissimus muscle that's got to get high, the skin paddle is actually the harder part, right? Because the perforator could actually be up higher, right? The perforator could be near the insertion of the pedicle at 6 to 8 centimeters, but you actually want the 12 centimeter piece of skin in there, or the 14 centimeter piece of skin in there. And that's the hard thing, because there may not be a perforator down at that level that would reach you there. So, I bet you if you took a huge piece of skin and brought it up to the intraorally and you left all that skin on there and just de-epped it all and left it, I bet you that skin would be fine in the mouth. But it's the problem is really just taking that little piece of skin in the mouth off the end of the latissimus muscle at 15 centimeters or 18 centimeters. It's the real problem.
Definitely. Do you specifically Doppler out perforators when you're taking it as a pedicle flap?
We don't. No, we don't.
Okay.
We treat it like a forearm.
Yeah.
And so it's we know the perforator density at zone 1 is really high. And so if you go, I know when we started looking for perforators at one point, and it's a disaster. It's a much different dissection. It's very hard to find perforators there. And so we realized just as long as it's at least a 4 centimeter width of skin, it pretty much always has a couple of vessels that come off of the pedicle to go in there.
When you all harvest in either the Mayo conformation or the spider arm, do you find it difficult to detach the medial spinous attachments from that position? Because we definitely do more of a MUSC style of either a full decubitus or a full turn. So I'm not familiar with that positioning.
It's actually easier. The detachments are way easier. Yeah, because the whole arm is being pulled out and up. And so it pulls the scapula away from the chest wall. And so it's easy to see all the attachments of everything. The harder ones are when, you're not in such a good position, you can't get the scapular tip out, but you can put your whole hand can go around the scapula and you can see all the muscular attachments in a spider arm.
Yeah, I think the other thing is occasionally if I do know I need to have, particularly for scalp reconstruction when I'm doing that, and I know I need to get a wider one, we put them up on a bean bag as well to kind of get them in that lazy lateral. And that allows me just to get a little bit further. But you really, as Matt is saying, with the arm out, it really pulls the scapula out, pulls the lat out, and you really have almost complete dissection to the midline. It's more some of the paraspinal blood vessels that become a little hazardous to ligate. But that's really about the only major limitation from the midline and paraspinal detachment.